Today we have Dr. Satish Nagula discussing management of Barrett's esophagus. Dr. Nagula is a senior faculty member in the Division of Gastroenterology, and he's the director of Endoscopic Ultrasound at the Mount Sinai Hospital. He received his medical degree from Yale and pursued his training in internal medicine at the University of Pennsylvania. He completed his fellowship in gastroenterology at Memorial Sloan Kettering, after which he received specialty training in advanced endoscopic procedures. Prior to joining Mount Sinai, Dr. Nagula served on the faculty at Stony Brook University School of Medicine on Long Island for several years. Dr. Nagula's clinical interests are in pancreatic diseases, biliary diseases, Barrett's esophagus, and other precancerous and cancerous lesions of the GI tract. He specializes in advanced diagnostic and therapeutic endoscopic procedures. His research focuses on novel procedural techniques to evaluate and manage malignant and premalignant lesions of the GI tract. Please join me in welcoming Dr. Nagula.
Thank you. Good morning. It's a pleasure to be here as the inaugural speaker for the academic year. It's a real pleasure to speak today about Barrett's esophagus when I actually wrote my personal statement for GI fellowship, which I can't say I always read all the applicants' personal statements, but my statement was about Barrett's esophagus and about stenting for malignant GI obstruction, which I'm fortunate enough that's still what I do and something I love to do every day. So let me just take a sample patient here, Mr. Hardy Burns. He's 55, he's a white male. No significant past medical history, nocturnal Gerd for many years on a PPI, denies any dysphagia or dinophagia on daily Prilosec, no family history of malignancies, occasional alcohol use, and is a daily smoker. And an exam, he's BMI of 39, weighs 275 pounds, otherwise normal exam. He's quite worried about Barrett's esophagus. His friend was diagnosed with esophageal cancer, and his friend never even had heartburn. So I'll take you through a little tour of how I approach these patients. We'll start with some of the things in the office when we think about the epidemiology and risk factors for Barrett's and esophageal cancer. We'll move to the endo suite, where I spend most of my days with diagnostic endoscopy and basics of Barrett's. We'll look at a clinical pathologic correlation. And then we'll eventually swing back to the endo unit where things get interesting with advanced diagnostics and therapeutics. So we'll start with epidemiology and risk factors. I think it's critical to really understand this disease and understand what we do know and how much we really don't know. So let's first look at the Ge Junction. This is something where many of you probably haven't looked at in quite a long time. And by a textbook definition, it's the anatomic region where the distal end of the tubular esophagus is in contact with the proximal extent of the gastric folds. Well, what that basically means, this pearly white mucosa here, that's all the squamous mucosa of the esophagus. And this almost salmony color is the stomach. And you can see these are the top of the rugal folds here. And so this here is your Z-line. And this is a pretty regular, normal-looking Z-line. Another example here. Here is your columnar epithelium from the stomach and the squamous and the esophagus. And again, your Z-line, which again here is quite regular. So another textbook definition. How do we define Barrett's esophagus? It's at least 1 centimeter of metaplastic columnar epithelium that replaces the normal stratified squamous in the distal esophagus with histologic evidence of intestinal metaplasia. So yes, the goblet cells are key here. So again, simply put, here is normal. Again, here's the normal stomach. Here's the normal Z-line. Now what we see is this long area here. The Ge Junction is way down there. And you see the salmon color extend several centimeters up the esophagus. That's Barrett's esophagus, assuming the biopsy show intestinal metaplasia. Same thing over here. The Ge Junction is way down there. And there's several centimeters of this sort of salmon colored here. And assuming the biopsy show goblet cells and intestinal metaplasia, then these are Barrett's esophagus. Of note, we will sometimes talk about intestinal metaplasia in the cardia here. That's a different disease entity. I'll direct you to one of our chief fellows, Dr. Salja Shah, who's spending her life fascinated by intestinal metaplasia of the stomach. But basically speaking, there's no evidence of malignant progression of intestinal metaplasia of the cardia in longitudinal studies. So that's the last I'll talk about the stomach, really. We'll go back to the esophagus. So again, something basic. So we just think about Barrett's esophagus. And we get the normal Ge Junction. And through Gerd, some genetic factors and some other factors we'll talk about in a minute, you'll get Barrett's esophagus. And again, here are those irregular tongues of salmon-colored mucosa. And then maybe Gerd, and then some genetic mutations within the tissue itself. And then eventually you'll get low-grade dysplasia. And then maybe through more Gerd, we're not sure if Gerd plays a role here, progressive accumulation of mutations. You get high-grade dysplasia. These are all histologic features. Maybe some small nodules, which might represent early cancer. And then eventually, this will develop into esophageal adenocarcinoma. And this is an ulcerated friable mass. In the scheme of things, this is still relatively small compared to what we often see. But this is the normal progression. And like anything else, if there is a progression, maybe there's an opportunity here to screen for the disease, to treat the disease, and maybe prevent the ultimate cancer, which has been what we've successfully done with colon cancer. So we look at the incidence. So Barrett's affects 0.5 to 2% of the population. So 5 to 15% of GERD patients. That right there tells you there's something more than GERD that's just going on, because most GERD patients will never get Barrett's. 16,000 new cases of esophageal adenocarcinoma in 2010, and about 14,500 deaths. So that tells you right away that we're not doing that well with esophageal cancer. Now, this number certainly pales in comparison to colon cancer, which is 160,000 new cases, and lung cancer, which is 250,000 new cases. But you can see from 1980s on, esophageal adeno-CA is rising rapidly, and this is in stark contrast to colon cancer, which is declining. And so if you look at relative change in esophageal adenocarcinoma incidence, colorectal, thanks to our success with colon cancer screening and the awareness that we have gone through the last 20 years, is starting to decrease. Lung and breast cancer, prostate, melanoma, but what's really on the rise is actually esophageal adenocarcinoma. And part of that has to do with some of the risk factors we'll talk about in just a minute. So who's at risk? Well, people come in all sorts of shapes, sizes, races, and each of these actually confers a very different profile of risk on our patients, and that's a very important thing to recognize, actually. So race is a big one. So here is a huge study from the United Kingdom where they basically looked at all comers who came in for upper endoscopy. And again, large numbers. You'll see almost 14,000 white Caucasian patients, 5,000 South Asian patients, and 1,000 Afro-Caribbean patients. And if you look at the number of patients with long segment Barrett's esophagus, only 2 out of that 1,000 of Afro-Caribbeans, and only 16 out of the 5,100 South Asians actually had long segment Barrett's esophagus. And again, odds ratio, if they use South Asians as the baseline, well, it's white Caucasians at a 6-fold increased risk. And then if we look at gender, again, large population studies, 20,000 patients. And again, gender's consistently been shown that males have at least a 2 to 3-fold increased risk of Barrett's esophagus. So if we look at GERD, so Barrett's, again, we talked about around 10% of patients with GERD will develop Barrett's esophagus. The longer duration of GERD, the increased risk of Barrett's. Hiatal hernia increases the risk of Barrett's because hiatal hernia increases your risk of GERD. So, but still the odds ratio for association of GERD with Barrett's is still only about 3. And then this is the result of multiple different studies, and we'll talk about GERD in just a second as well. And here's where it's challenging. Only 20 to 80% of patients with Barrett's actually have GERD symptoms. Now, is this because Barrett's develops in the absence of GERD, or is Barrett's your body's adaptation to GERD, much in the way you might develop a callus or something? And so maybe patients had GERD, and then their bodies adapted, and they developed Barrett's, and now they no longer feel GERD. Anecdotally, I've had a lot of patients who are like that. That hasn't been entirely proven, but we'll see that with some of the data that's available. So here, on this slide, we're talking about, we looked at 50 patients who have GERD and Barrett's. And if we look at the Barrett's patients compared to the GERD patients, and what they did is they looked at symptom scores. And they found that in the Barrett's patients, they actually had much lower symptom scores than the GERD patients. Okay, we're talking about chest burning and so on. But if you did pH studies, and we do horrible things, we put probes down their nose and measure all the pHs and things like that, well, we find that objective scores, the Barrett's patients have a much higher score. All right? So again, lower symptoms in the Barrett's patients, higher measures of objective reflux. So that's already of concern, and it speaks to a little bit what I have just mentioned. So again, lower symptoms despite more objective GERD and Barrett's, more manometric abnormalities. So if we look at the peristalsis of the esophagus, there's a lower esophageal resting tone, and that's going to predispose to reflux. Lower rates of peristalsis, so you might get a lot of stasis of contents in the esophagus. Longer reflux episodes in our Barrett's patients. Another study looking at reflux in Barrett's patients, they actually took a bunch of Barrett's patients and they held their PPIs. And they did pH testing, PPI titration, and they tested them again. And so they found that at baseline, and then if you define all these patients up here as having GERD on objective measurement, most of the Barrett's patients had GERD, which is not surprising to us. You put them on 20 milligrams BID of a PPI, we call standard double dosing. And most of those patients no longer have GERD, but 2 out of the 20 still had reflux, although all their symptoms were gone. Now, 10 to 20%, those 10 to 20% with persistent reflux, well, then you put them on high-dose PPI, 40 BID, and now everybody's objective GERD and the symptomatic GERD all went away. So again, speaking to the fact that there's a lot of GERD that happens in these Barrett's patients and they don't really feel it. So now let's talk about obesity. So obesity increases GERD. There's a great number of patients that I've seen who they've gained a lot of weight over the previous 10 years, like 2-3 pounds a year, like many people in their 50s, and then by the time they've gained 30 pounds, you're coming and saying they have terrible GERD. Well, GERD disrupts the Ge Junction anatomy and physiology. You've got a lot of intra-abdominal pressure, a lot more reflux of contents, and those patients who elect to just forget the meds and just lose weight, they feel great. They feel much better. So metabolically active adipocytes and central obesity release pro-inflammatory cytokines. I think it's underappreciated that obesity, at least in the lay public, obesity is in some ways a carcinogen. It's a precancerous state. And so we get to this eternal apple versus pear debate, and in sumo wrestler fashion. And the meta-analysis shows no association between BMI and Barrett's. However, there is a dose-dependent association between central adiposity, looking at like weight-hip ratios and so on, and Barrett's. So the more central adiposity a patient has, the greater the likelihood they are to have Barrett's esophagus. Again, in patients who are more like the pear shape, those who are not centrally obese, they don't really have an increased risk of Barrett's esophagus. Same I know is true that we've seen for diabetes and cardiovascular disease and so on. So a table out of our recent guidelines from the American College of Gastroenterology. Certainly, with every 10-year increment, there's an increased risk of Barrett's esophagus. Smoking is something that's underappreciated. There's an odds ratio of 2. So those who are smokers are at double the risk for Barrett's and esophageal cancer. We always think of squamous carcinoma being a smoker's cancer, but it has a pretty big impact on esophageal adenocea as well. Family history, 12-fold increased risk. Family history of Barrett's, esophageal cancer, or Ge Junction cancer for giving their first-degree relatives Barrett's esophagus. So who are we worried about? This guy? Or this guy? I'm not going to make any political statements here, but he's got a lot on his mind. And there's, of course, your friend of mine. I'll let that hang there. So listen, he's over the age of 50. He's white. He's male. Again, age over 50. Central obesity, of course. And I don't know, maybe he smokes. But either way you think that that's the constellation of the patient, you're very much worried about developing Barrett's esophagus and esophageal adenocea. So much so that for the first time, and so 2016 in our guidelines this year, they actually do permit, as a strong recommendation with moderate evidence, screening for Barrett's esophagus in men with chronic heartburn over 5 years and frequent symptoms of GERD with 2 or more risk factors. So age over 50, Caucasian race, central obesity, smoking history, and a confirmed family history. And that's the first time there's ever been a real formal guideline from the GI societies actually advocating for screening for GERD. It's a pretty enriched population, but that is the population with all the risk factors I've showed you that might be of benefit. Remember, esophageal cancer is not as common as colon cancer, so you can't really mass screen the population in the way that we do it, which is endoscopy. So fine, let's move over from what we think about in the office to how we approach endoscopy. So we're going to proceed with screening EGD for Mr. Hardy Burns, and we order the endoscopy in Epic. And there's that screen. And I said, there's a lot of things to click. Although, thank you, Dave, it's much better now. A lot fewer things to click. But you might end up doing this, staring at Epic some days. But let me switch to the other side, as we often do in GI. And let me go to colonoscopy for a second. So 10 years ago, there was a huge study in the New England Journal. And it discovered something that most people think is common sense. That the more time you spend looking, the more polyps you're going to find. Strikingly enough, this was a major revolution and caused huge waves in the GI community, which most people would say, really? Your mom has been yelling you to do this for many years. And here's a great graph showing the amount of time you spend looking for polyps and the number of polyps or adenomas you found. And this is an R of 0.9. That doesn't happen in medicine very often. This has been repeated again and again and again, showing that the more time you spend looking for colon polyps, the more polyps you find and the more cancers you prevent. They've taken it to that level of analysis. So they said, maybe this is true for Barrett's esophagus. Granted, this is in a referral base. This is a group of patients that all had high-grade dysplasia and maybe early esophageal cancer referred for endoscopic therapy. And this is from a very rigorous group in the Midwest. And what they did is they actually timed all their endoscopies. So they knew full well these patients had high-grade dysplasia. But what they found is that the longer time they spent staring at the Barretts, so greater than 1 minute per centimeter, 50% of those patients they were able to find visible abnormalities of esophageal cancer, compared to those with less than 1 minute per centimeter. Now, granted, most patients with Barrett's have 3 to 6 centimeters, so to spend 6 minutes in a 2-inch area is kind of a long time. But the point is well taken. There's a strong correlation between inspection time and finding suspicious lesions. So much as we've said for colonoscopy, slow down, spend more time looking for polyps and preventing cancer. The same is true for Barrett's esophagus, and that many times you might whiz through the Barrett segment for maybe 10 seconds, 15 seconds to take a few biopsies. Slowing down and taking a couple minutes, you might find visible abnormalities that may show that they have more advanced disease. Barrett's is quite patchy. The malignancy may develop in any portion of it, so taking more time to look may really be of benefit. Narrowband imaging. So this is something that has been on the market for several years, and it's a way of using different light on the endoscopy to enhance the tissue. Normally we use white light, all spectrums of light mixed together to give you white. And so if you put that into a filter, and now you make it either a blue and green light, what it looks like at the tip of the scope is blue, well, what that does is, here's an image. We're looking, this is in the stomach, and you see a small bump here, and you really don't know what to make of that. Well, using narrowband imaging, you highlight the blood vessels and you highlight the superficial mucosa. And now, this indentation becomes quite significant. There's a very abnormal vascular pattern. The texture of this tissue is very different. This is actually very early gastric cancer. So my point in mentioning this is there are a lot of subtleties that happen to Barrett's esophagus. So here is a trial that was done in 2008 when this technology was really first mass introduced. So back then we were basically using standard definition endoscopes, which again is striking. And this is one esophagus, looks pretty normal. Same patient, high definition. You start to see some subtle texture and some subtle irregularities here. Now under narrow band, you can see this now very clearly. This is pretty normal, and this texture and nodularity is quite obvious here. So this is an example of where technology that's available in all of our scopes now, this is cancer. This is a very, very early esophageal cancer, which could still be amenable to endoscopic treatment, as opposed to that patient that's diagnosed at stage 3 or 4. And what they've shown now in multiple studies that, generally speaking, narrowband endoscopy does end up detecting more dysplasia when you compare to at least standard definition white light. Now that everybody has high definition scopes, some of the studies show no difference, but I think there's just more data to come. But taking an extra minute or two just to examine a short area can really make a big difference to finding these subtle lesions. So we'll go from diagnostic endoscopy in Barrett's, and let's move over to a clinical pathology correlation. This is where I think this gets interesting a little bit. So we talk about Barrett's esophagus. That's a length of disease in the distal esophagus. Now that could be a centimeter in some patients. It could be 12 centimeters in some patients. So they took 1,400 patients with non-dysplastic Barrett's and a prospective database, and they followed them for 5.5 years. And what they found is there was a 28% increase in risk of high-grade dysplasia and cancer for every 1 centimeter increase in length. Now, as a frame of reference, the upper esophageal sphincter is maybe around 15, it's about 40, so it's about 25 centimeters is the length of the esophagus that we really examine. So for every centimeter increase in length in Barrett's, there's a 28% risk of increase, a 28% increase in risk of high-grade dysplasia. So another way is to put it, this is somebody with very short segment Barrett's. This is one tongue of Barrett's. Here is another tongue of Barrett's. It may be a centimeter, centimeter and a half. That risk is much lower than someone like this, who's got 6 centimeters of circumferential Barrett's all around. It's sort of a surface area issue. The more area there is of Barrett's, the more opportunity there is for things to go bad. And there's a huge difference between this short segment disease and long segment disease, without question. So risk of progression to malignancy, and this is a question a lot of patients ask. Now, Barrett's, strikingly enough, arises a lot of emotions in my patients. So patients will come, they've been diagnosed with Barrett's somewhere else, and they're literally in tears because they've gone on the web and they've read about Barrett's and esophageal cancer, and they're patients who are on antidepressants. This really freaks people out. And so it's good to know, what is the risk of progression to malignancy? The risk of cancer of patients with non-dysplastic Barrett's is about 0.2 to 0.5% per year. That caps, that's not an infinite risk. I'd say it's somewhere around 2 to 5% in someone's lifetime. Low-grade dysplasia, at least in some of the meta-analysis, is only 0.7% per year, and high-grade is 7% per year. This highlights the importance of expert centers. So coming here to Sinai, where we have expert pathologists, what ends up happening is low-grade and high-grade dysplasia are often downgraded after expert pathology review. So getting the diagnosis correct actually makes a pretty big difference. So when you go to the studies with expert review, low-grade dysplasia now progresses to cancer at a rate of 10 to 12% per year. That's a very serious risk for an otherwise pretty healthy 50-year-old. High-grade dysplasia, it's 20% per year progress on to cancer. So again, expert pathology review, careful attention to details has a huge impact on this disease. So now let's think about biomarkers. We're thinking about personalized medicine every day. We're thinking about trying to stratify our patients, and we see this in the oncology world all the time. So they did a case control study of Barrett's patients with low-grade dysplasia, comparing to those who looked at those who progressed to high-grade dysplasia. And they looked at p53 staining in the tissue. So, and we know that p53 is implicated in a lot of cancers. And they found that p53 overexpression has a relative risk of 5.6 for progression. Loss has an even higher risk, relative risk of 14. So here's somebody with an overexpression of p53, and here's someone with complete absence of expression in p53. So abnormal p53 progression actually really shows that those patients are at increased risk. So now we can start to think about how to stratify our patients. So positive predictive value of low-grade dysplasia for progression is 15%. When they have a Barrett p53, that jumps to 33%. And so our group here, although this hasn't been advocated by our national societies, our group here actually routinely reports this, and this is actually quite helpful when I stratify my patients. So let's go from what we know about the disease and correlating the clinical outcomes and the pathology back to the endo unit and look at some of the advanced diagnostics and therapeutics that we have. So with therapeutics, we have two ways to go about Barrett's esophagus. At this point, I've hopefully convinced you, or at least illustrated, that Barrett's is a pre-malignant condition. There is a real risk of progression to cancer. And now we have great endoscopic therapies to treat this. So in ablation therapies, we destroy the epithelium and it will allow for normal tissue to come back in its place. From mucosal resection, anybody with nodules, and those nodules could be high-grade dysplasia or adenocarcinoma, those can actually be resected endoscopically instead of surgically. So here's some of the ablation tools that we use. Here's our generator, and this is actually a balloon with an electrode wrapped all the way around it. This uses radiofrequency energy, similar to what they might use in cardiology for AFib ablation or in the spine where they do ablation for nerves. And then these are little focal catheters, which look a little bit like fake press-on nails. And again, these are copper electrodes, and we use that to contact right against the mucosa and burn away that superficial epithelium. Here's a little cartoon schematic. Here's the balloon here. Here is that salmon-colored mucosa we talked about. We inflate the balloon, apply thermal energy, and then now you get a zone of coagulation and a burn. And then we repeat the area for the next segment down here. Focally, we can do the same thing. This is a little area of Barrett's. We contact the mucosa and burn it. And then we can shift the catheter around to treat all the areas that we see. So in video form, here's a patient with like a 5 or 6 centimeter segment of Barrett's esophagus with low-grade dysplasia. We're advancing the catheter down here into the stomach. And all of this will be done over the wire, so it'll guide our catheter. Here's that copper electrode right there. This is wrapped around a balloon. And then this is the esophagus. So what you'll see in a second, the balloon is inflated. You can kind of see looking down the tunnel here. And then energy is applied, and the balloon deflates automatically after a second or two. And then what you'll see is this perfect 360-degree burn of the circumference of the esophagus here. And that goes just deep enough to the mucosa to basically burn away the intestinal metaplasia to allow for normal tissue to regenerate in its place. And then here you see we've scraped off some of that scar tissue. And now at the end, you can see that that area is nice and burned. And then we'll come back again 2 months later. So the patients will feel pain, and they do feel some burning afterwards, but it goes away within a couple of days. And I'll show you some data on this. This is an alternative to an esophagectomy. So an esophagectomy, here's somebody with a cancer in the distal esophagus, and every time I describe it to a patient, their jaw drops on the floor. We take out the esophagus and we take the stomach and we shift it into the chest, which is a really drastic, dramatic surgery. And our techniques have gotten better and our surgeons are extraordinarily skilled. But at the end of the day, the physiology of the stomach and the chest, a negative pressure space versus the abdomen where you can expand until whenever, it's a huge change. Patients are always full. They're constantly refluxing. And the motility is totally disrupted. It is a very, very difficult surgery. 1 to 2% mortality, 30 to 40% morbidity with delayed emptying and leaks and strictures and so on. This is still what we do today for cancer. This is what we used to do for Barrett's with high-grade dysplasia until this ablation technology came along. So then the next step that came is, what about these patients with these small early cancers? What if you're able to survey these patients close enough and they have a small cancer? What can you do? So here's a patient with a cancer that basically goes through deep into the mucosa, sparing the submucosa, the muscularis propria, and the adventitia. So in somebody with a mucosally based cancer, we know from long-term studies that risk of lymph node metastases is only 1 to 5%. And that's what's going to confer a patient's later cancer recurrence. So patients with low risk of lymph node mets can be cured with an endoscopic therapy. You can just cut this out and they'd be cured. If the tumor extends now deep into the submucosa, now the risk of lymph node mets approaches 25%. This is where surgery can be advocated because not only do they take out the diseased part of the esophagus, they do a lymph node dissection and eradicate the entire disease. So those are the patients that typically require surgical resection. So how is this done? So we take a patient who's got this tumor here, and I'll show you a video in a moment, and we basically suction up that lesion and put a big rubber band at the base of it, literally a rubber band. And now you've made something that was kind of flat into a polyp. We're pretty good at polyps. What we'll do is we'll take a snare and cautery, and we'll actually just literally cut out at the band. And now you've created this large divot, and you can see the muscle deep to that. Send it to pathology, and they will tell us hopefully that there's a clean, deep margin in the same way that a surgical oncologist is looking for. And that is effectively a cure for these patients. So here's a patient here. You can see that we're down in the distal esophagus. Here's that pearly white mucosa. And here there is some nodular tissue, which has been shown to be adenocarcinoma. And so the first step you're going to see here, here's this cap that we talked about, and these are these rubber bands that are there. We're going to suction that tumor right into the cap. You see it's lifting right up into us, and then we'll throw a band right at the base. And what that's done is it's created a little polyp. So that'll fall out of the cap, and you can see that black band is there. There's a little polyp like that. And now we take a snare, which is basically a metallic lasso attached to cautery, and we'll burn it off. And you can see there, and then we repeat this for the entire nodular area. So here's the second band, and this patient required a few different bands. I usually go into AFib in the middle of this procedure. So again, burning that off. And so at the end, what you're left with is this deep divot in the mucosa. This is all muscularis propria that we're looking at. And all those tumor pieces we've grabbed out and sent to pathology. And this is a patient that had esophageal adenocarcinoma extending into the mucosa, and we had clear, deep margins. And so now, 2 years later, the patient is free of disease, has no esophageal cancer, never had an esophagectomy, never had chemotherapy, and now is just under endoscopic surveillance. So more than showing what we can do, I think it's important to know what the outcomes are. And so for a look at the large meta-analyses of endoscopic therapy, we look at remission from intestinal metaplasia, remission for Barrett's. It's about 78%. Remission of dysplasia is about 91%. Now that we've been doing this for about 7, 8, 9 years, we started to see some recurrence. So about 7% of Barrett's patients will occur per year. They'll have their Barrett's come back, and 1% will have dysplasia come back, which is fine. There's no predictors of recurrence yet. We can easily manage recurrence with just endoscopic therapy. So it's no longer, you can't just do the procedure and then say, goodbye, have a nice day. They're going to need surveillance. Here is a group out of Amsterdam. This is an extremely technically skilled group out of Amsterdam. They've done a lot of the big theories in Barrett's esophagus. Kind of a busy slide. But what they did was They said, let's just throw everything we can at Barrett's patients in a single center study at an expert center and see how good they can do it. And they did. It's a very aggressive protocol. Almost all of these Barrett's patients with high-grade dysplasia or cancer had EMR, and they had incredibly high remissions from dysplasia, 98%. 93% remission from intestinal metaplasia, low recurrence rate, 4% recurrence rate for dysplasia and 8% dysplasia. And again, the same numbers again, 98% eradication of all neoplasia. So this is an incredibly effective technique in expert hands under close surveillance. So I'll spend a couple minutes on endoscopic imaging. So this is confocal laser endomicroscopy. So here's a regular endoscope, and this is the little probe we can put through the endoscope, and what that does is it allows us to look at the microscopic detail of the tissue. So no longer just looking at the shapes and the colors, now we can get down to the microscopic level and maybe detect a dysplasia real time while we're doing an endoscopy. So an optical biopsy is like a horizontal cut. It's like an axial cut across the tissue. A vertical cut. So as you take a big bite, you're seeing these cross sections like this. When we're doing these optical biopsies, we're taking this probe and gliding it across the mucosa. So you're getting these axial sections, and here you're seeing samples of the actual mucosal layers. So my point is here, this is normal Barrett's esophagus, and these dark circles are the goblet cells. And now here's somebody with obvious cancer. You can see this tremendous disorganization, disarray of the tissue. And so this is the detail that we are now starting to see with some of the new endoscopic technologies. Where it fits in, I think there's still a lot of discussion, but the point is that now that we can see this detail, maybe we can take some of these endoscopic tools and refine them and use them in a more targeted fashion. Similar is true for this one. This is the new kid on the block. This is a balloon. It's called volumetric laser endomicroscopy. There's a little optical fiber that spins in there, and you get 1,200 frames in 90 seconds. What's neat about this is not only did they give you this big shiny screen with this like fancy touch screen, but more importantly, you get this fascinating CAT scan of the esophageal wall. And this is unbelievable. And you're getting all the different wall layers, and you literally will scroll up and down and go through axial and coronal sections of the esophagus. What's great about this is you see these tiny details. Like here is a tiny gland cluster that's deep to the mucosa. And this is actually a foci of low-grade dysplasia underneath the mucosa. Now that you can see through the wall with this virtual CAT scan, you can target your therapy and actually resect this and put this patient in remission. So all those treatment failures might be for patients with buried disease or subtle disease that we didn't really appreciate. Again, a lot of gizmos that are out there, and the data is still in its infancy, and I think it's upon us to sort of figure out who's going to benefit from these advanced technologies, and can they refine what's already a good procedure. So I still have questions. This is some of the advanced endoscopic stuff, but there's some major important questions that we have to look at in our broader population of patients. So which of your GERD patients needs an EGD? And this is a question that comes up all the time. Looking at all the society guidelines, there's basically a couple of broad categories. We talked about this group: men, GERD for 5 years, 2 risk factors, obesity, age, Caucasian race, family history, and smoker. You need an EGD there, you get a screen for Barrett's esophagus. And that, again, is a new guideline, but that's an important one. GERD symptoms refractory to PPI. So you've got patients who are on a single dose PPI or double dose PPI. Those patients might need an endoscopy just to look for complications. Maybe they have strictures and stasis causing their burning. Maybe they have achalasia. Maybe they have refractory esophagitis from bile reflux. Maybe there's alternative diagnoses, eosinophilic esophagitis, or maybe they have malignancy. Oftentimes a sign of malignancy is a 70-year-old who's got GERD out of the blue, never had it in their life. That's a sign of malignancy. Alarm symptoms, dysphagia, weight loss. Well, that's another one we always think about in terms of searching for malignancy. Now, a lot of patients have dysphagia and GERD just from esophagitis and dysmotility, and you give them a PPI and they get better. But in the right patient, you really want to screen for malignancy. So, importantly enough, no role for endoscopy in the evaluation of typical GERD symptoms. There's no question there's an overuse of upper endoscopy. In a patient who's 25 years old, has ordinary GERD symptoms, and they drink a lot of alcohol followed by a lot of coffee, and have NSAIDs to deal with the hangover, and they have terrible GERD symptoms, and they get better on PPI, they don't need an endoscopy, right? And those patients who have just ordinary GERD, somebody in their 30s and 40s, gets better on 8 weeks of PPI, that patient doesn't need an endoscopy. What are you going to find? Maybe esophagitis, probably not, because you've already treated them with a PPI. Are you thinking about Barrett's esophagus? Well, we know which group is at risk for Barrett's esophagus. If you have a sort of thin African-American female, they're almost never going to get Barrett's esophagus. And many people advocate don't screen those patients for Barrett's. They're never going to get it. You have an overweight white male, it's a different story. So can acid suppression prevent Barrett's esophagus progression? This is a very difficult question to answer. One meta-analysis says there's a 70% reduction in high-grade dysplasia and cancer with use of a daily PPI in patients with Barrett's. A large Danish study says there's an increased cancer risk with PPI use. Most observational studies suggest PPIs reduce cancer risk. Now, the complex side effects of PPIs is another grand rounds for another day. But most esophagologists and Barrett's experts kind of ignore all of that noise because they really think the benefits to Barrett with PPIs far outweigh the weak data that suggests there are complications to PPIs. So most patients on PPIs have symptomatic Gerd. Makes sense. That's why they're on a PPI. What about the asymptomatic patients? Let's take this a step further. Back in 1999, this is when the seminal study that reported that heartburn was associated with esophageal cancer. They took patients with esophageal adenocarcinoma in a case control format, and they found that those with heartburn, regurg, or both at least once a week had an odds ratio of 7.7 compared to those without heartburn. So that's 60% of patients with esophageal cancer had heartburn. Great. What about that number? 40% of these patients with esophageal cancer never had heartburn. That's a big number. So let's take this a step further. So we have esophageal cancer. 60% of those patients have had Gerd. Let's say you take all of those patients. You identified Barrett's during an evaluation of Gerd somehow. And you took all of those patients and put them in a surveillance program. So here's the rub. There's no randomized trials to support surveillance. Surveillance programs do lead to earlier stage esophageal cancer. That's been shown. And earlier stage esophageal cancer does have improved survival. That much we know. But the data, it's very conflicting. Some studies show no benefit at all to surveillance. Granted, most studies are before the modern era of endotherapy. All the things I showed you were in the last 5 years. And so a study that incorporates surveillance and endotherapy might actually be more effective. Theoretically, this should, right? Surveillance and endotherapy should be effective. So fine, that's great for that 60%. What about the 40%? Well, that keeps you up at night, right? What are you going to do about those patients? So what are some solutions? We had colon cancer awareness right downstairs. We had a big inflatable colon downstairs. Maybe we need more surveillance programs. We had Dave Greenwald out there for 8 hours like an auctioneer talking about trivia for colon cancer, literally like nonstop. We had my partner and colleague, Chris DeMeo, sitting there taking out fake polyps with this inflatable endoscope. Maybe we need that level of awareness so that patients start to think about, maybe I do have a lot of Gerd, maybe I do have some dysphagia. Did you know that April was Esophageal Cancer Awareness Month? No. So it just goes to show that it's out there. There are purple ribbons out there. But again, this is a disease that's rising in incidence. We all see the rising rate of obesity, which is clearly linked to the rise in incidence of the disease. And certainly more awareness will help. But that's only going to help for those 60% of patients that actually have Gerd. So we need something disruptive, some new technology. We can't screen everybody with upper endoscopy. It's too expensive. There's sedationless transnasal endoscopy. This is gaining traction. It's used all the time in Japan for screening for gastric cancer. They have very intense screening protocols for gastric cancer. And it's basically like those of you who've had an ENT eval where they go down your nose right into the larynx. Well, same scope, take a longer scope, go right into the esophagus, and you could take biopsies and assess Barrett's that way. That would drive the cost down dramatically. Another new technology, this thing is very cool. It's called cytosponge. A little bit like those little pill things you got as a kid. You threw them into the sink and it turned into like a big dinosaur. Same concept. Here's a great little video. And so the doctor gives them the pill attached to a string, drink some water, down it goes. And this is out there. This is in trial. Pill dissolves. This is an awkward 5 minutes. You're sitting there with somebody holding a string. And then you pull this up, and this is a big cytology brush. You're scraping the entire esophagus getting cells. And here are the tissue samples. They're pretty impressive. So whatever cellular yield you get, you can actually do immunostains. And some of those biomarkers we talked about, there are other biomarkers that you can use on low cellular yield to predict Barrett's esophagus. And maybe there are biomarkers that are under investigation that might predict progression of disease. This is in a trial of 1,000 patients. Had an 87% sensitivity for long segment Barrett's when compared to endoscopy. This, as you can imagine, is quite inexpensive and quite easy. And maybe that's the way you start to access some of these patients who are at risk. So here's our current approach to Barrett's esophagus. there are people that we say are increased risk of Barrett's, however you define that. They get a screening endoscopy, they have Barrett's, they go to a surveillance program. Maybe we'll get better biomarkers, and maybe we can predict who's going to progress. Maybe those are the patients we can look at more frequently. But imagine a new arm. Now we have these cytology techniques that are non-invasive. So now you take all these patients and you have them swallow this pill and do some of the cytology brushing. If it's negative, great, no further testing. If it's positive to show for Barrett's or for high-risk disease, maybe they get an endoscopy. Or maybe we'll have a new panel of biomarkers. And those who've got a real high-risk panel of biomarkers, maybe those are the ones who get scoped. And everybody else comes back a year later for a repeat pull-through. Maybe we'll do a clinic downstairs outside by the inflatable colon. So long and short of it, Barrett's esophagus in all of its various stages. Low-grade dysplasia and high-grade dysplasia. Endotherapy is highly effective. It is now first-line treatment. I've seen this evolve over the last 10 years when it was sort of a consider endotherapy, and now the guidelines in all societies firmly recommend endotherapy as first-line for low-grade dysplasia, high-grade dysplasia, and early cancer. Certainly, more outreach needs to be done because certainly many practitioners don't buy it and still send to surgery. But many surgeons will refer these patients to us. It's a morbid procedure. And when surgeons are sending them back to the gastroenterologist, we know that we've stumbled onto something very effective and very safe. We can manage the recurrence. New technologies that I've showed you will just optimize this further. Interestingly enough, when I would give this talk 5 years ago, this was where the question marks were. Now the question marks are over here. We understand some risk factors for Barrett's esophagus. We still don't know exactly who's going to develop Barrett's. We don't know which patients will progress. We have to follow proper endoscopic techniques for surveillance and taking our time, but I think there are new technologies on the horizon that I think that could really open up the screening opportunities. The goal in the end is to prevent esophageal cancer. We've accomplished some of that, and hopefully there'll be more to come. Thank you.
We have time for questions.
Hi, great, thank you, excellent. For the
Cytosponge.
yeah, for the cytosponge, what level provider was doing that, and how do you envision that to be done?
I envision that to be done in the primary care setting. I mean, this is easier than a pelvic exam in all reality. It's very safe. Patients, I mean, they've actually done a lot of quality of life and sort of patient experience questions about this. And universally, they feel great about it. And so I actually envision that in a primary care setting, pull the sample out, drop it into a jar, goes to the lab. Very similar to, I think, stool DNA, that type of testing.
Several of the people in the audience work in our division or our program in geriatrics. So you know we think about aging. And there's an interesting aging aspect, I believe, to this disease.
Absolutely.
I believe that if you take older people at 60 and over, 65 and over, the new onset of BE is not too frequent. If that's true, how do you use that? What are you doing about that, you or your colleagues, in terms of research or the approach of this problem?
There are a lot of weird things about Barrett's in that many patients, like the first time you scope them, if they have Barrett's, then that's the extent they'll have. They'll never get more, they'll never really recede, and that's what they'll have. And so there's an advocate for saying, you scope them at 50, you never need to really scope them again if they have no Barrett's. In patients who are older, I think this is a different question than from colonoscopies, because the prep for the colonoscopy is quite difficult and quite debilitating for patients from the dehydration and so on. With an upper endoscopy, I would readily do an upper endoscopy on a much older patient than I would do a screening colonoscopy. So in a patient who's got, again, some of the paradigms we discussed in terms of those men who are overweight, long-standing Gerd, those patients should still get an upper endoscopy if they're in their 70s and even in their 80s. I'll even put them through endoscopic therapy if they're a pretty healthy 80, 85-year-old. Because going through malignancy at that point, the treatments are just too morbid. So it's not an entirely direct answer to your question. I think it just comes back to risk profiles and who can we predict have Barrett's esophagus. But I think it's different from screening colon just because upper endoscopy is so much easier to tolerate and easier for patients to handle.
Mike, you have a question? Yeah.
Okay, so I would like to focus on just one aspect of why you might develop a cancer at the site of the Barrett's esophageal problem. You were saying that there's an increased incidence with smoking. So with smoking, is there a significant concentration of particulates, of tar, of carcinogens in that area? And does Barrett's then make it linger even longer? Could this be why there's an increased incidence?
That's a good question. I think some of what's known is that I do think smoking has an increase associated with increased risk of Gerd, and you get some alterations in the mucus of the GI tract, and so it may not be able to handle the acid like it might have before. Whether it's related to the particulate matter in smoking, I just don't think we know. And again, it's only a twofold increased risk, so it's not a massive risk, but I think it just contributes a small piece.
Two questions. What does H. pylori do to this disease, and in terms of eradication? And two, the surveillance, is it every year, every 2 years? What's the
Good question. It's another one of those challenging overuse of endoscopy issues. Those with Barrett's esophagus, the guidelines have been paring back. It used to be 2 years without dysplasia, then it was 3 years, and now they even say 3 to 5 years for Barrett's. Most of us will do 3 years. If you are a little bit younger, if those are a little bit older, you might go for 5 years. When you start to get dysplasia, then if you don't choose endotherapy, then it starts to go every year or every 6 months. And then H. pylori, oh boy. H. pylori is just a mess. I don't think there's a clear association with H. pylori and certainly esophageal cancer and Barrett's esophagus. There are some issues that if you treat H. pylori, maybe you'll get increased Gerd, but that hasn't ultimately resulted into more Barrett's and more esophageal cancer. And again, Gerd is only a small piece of this. There's a genetic component, obviously, with all the gender and all the inflammatory cytokines of obesity. So they haven't seen that H. pylori has led to that increased risk. They've been such large enough studies at this point that I doubt we'll see a tie.
So one more question from Mark.
Do you recommend PPIs for patients with Barrett's and no dysplasia and no Gerd?
I do, actually. Because of the fact that so many Barrett's patients have objective evidence of Gerd on pH testing, and they don't feel it anymore. I again think of Barrett's as their sort of body's ability to adapt. And so the only thing we can control is I tell patients to lose weight, because that's clearly a modifiable risk factor, and the only other modifiable risk factor is Gerd. And so in the fact that I know that many of them have silent reflux, that I will indeed put them on PPIs. Just once a day, no need to go double dose, high dose, BID, and so on, once a day. But I do, until we know more, it certainly makes a lot of sense. Again, there are very few modifiable risk factors that we have. But my practice shifted. I used to put everybody on PPIs. Now I spend a lot of time counseling weight loss. That's a good percentage of what I do in the office now.
Thank you.
Great. Let's thank Satish for